Let me introduce you to oxycodone, a semi-synthetic derivative of natural opium alkaloids that has been around for 28 years in Australia and was initially synthesized in 1916 at the University of Frankfurt in Germany by Freund and Speyer. It derived from the modification of the chemical thebaine, an organic compound found in the opium poppy plant. Cultivation of the opium plant dates back to the earliest years of human civilization, and it was well known to ancient Greek and Roman physicians as a strong pain reliever with pleasurable effects. It was also used to induce sleep and to give bowel relief. Opium was also thought to prevent the user from being poisoned. Oxycodone creation came after the cessation of heroin and morphine due to their hazardous and harmful use and dependence. It was hoped that oxycodone would retain their analgesic effects but with less dependence. However, this was not the case.
Oxycodone is mainly used to manage moderate to severe pain. Oxycodone mimics the effect of endogenous opioids. All these molecules target opioid receptors, especially mu-type receptors. Opioid receptor is a member of G-protein coupled receptor, meaning that a G-protein is attached to it. When an oxycodone binds to the receptor, it activates the G-protein and separates into two subunits, alpha subunit and beta-gamma subunit. In presynaptic neuron, the G-protein interacts with voltage-gated calcium channel and prevents them from opening. No calcium ions can flow in, therefore no neurotransmitter can be released. G-protein interacts with potassium channels in postsynaptic neuron. However, this time it opens the channels so positively charged potassium ions flow out through the channel, thus no action potential can be formed. Through this mechanism, oxycodone blocks the ascending pathway, and the pain signal no longer reaches the brain, and pain relief is achieved. Oxycodone can bind to the inhibitory neuron in ventral tegmental area, and force the dopaminergic neuron to release dopamine. When you stop taking opioids, the inhibitory neuron loses the binding of opioid receptor and shut down the dopamine release. That is when you experience withdrawal symptoms.
Starting from the precursor thebaine, either oxidant hydrogen peroxide or oxidant M-chloroperoxybenzoic acid is deployed to oxidize thebaine to intermediate 14-hydroxycodeine. The conjugated carbon double bond in 14-hydroxycodeine is in turn hydrogenated via either oxime products or by sodium hydrosulfite in formic acid to synthesize oxycodone. In vitro testing using cells containing recombinant human opioid receptors have exhibited the way in which oxycodone has high selectivity for mu receptors and is a potent activator of these antinociceptive receptors, engendering analgesic euphoric effects, which can also be liable for drug abuse. Moreover, in vitro testing has shown that it does not cause psychotomimetic effects such as delusion and delirium, salvation, diuresis, or dysphoria, which is the opposite of euphoria, which would otherwise be synonymous with K-opioid agonist activation. In vivo testing of oxycodone in mice has demonstrated oxycodone's antinociceptive action through use of a hot plate, paraphenylquinone, and a tail flick assay in which high-intensity light was directed at the tails of mice, thus acting as a mu-opioid receptor agonist. Oxycodone was administered subcutaneously and was only blocked by the mu-opioid receptor antagonist B-phenyltretsamine, which was administered intracerebroventricularly, showing the way in which oxycodone is a potent mu-opioid activator. Oxycodone is very similar to morphine in structure, having the same general opioid pharmacophore of a benzene ring attached to a quaternary carbon connected by a 2-carbon linker to a tertiary amine. Differences, however, can be highlighted at C3, C6, and C14 positions. It was particularly important to maintain the positioning of the tertiary amine here, as it was found to be integral to the function of the entire molecule. The addition of an ether group decreases the molecule's affinity for the mu receptor, improving the bioavailability of the drug. It also prevents the extensive first-pass metabolism undergone by its parent molecules morphine and thebaine. The ketone group, and the necessary removal of the unsaturated bonds in the original aromatic ring to accommodate for this, contributes greatly to increasing the potency and lipophilicity of the drug. Finally, the hydroxyl group increases the mu receptor agonist property of the opioid, making it a much more effective mu receptor agonist than its parent molecules.
Oxycodone's formulations come under two main types. There's the instant release forms, which are used for acute pain, and then there's the controlled release forms, which are used for chronic pain. So first off, the immediate release forms, they typically come as a tablet, capsule, suspension, suppository, or an injection, whereas the controlled release forms, they only come in a tablet form. So with the instant release tablets, we can expect a much faster onset of action of about 10 to 30 minutes, and this effect usually lasts up to 3 to 6 hours. On the other hand, we have the controlled release tablets, which have a much slower onset of action of about an hour, but this effect lasts for 12 hours. Now, regarding oral tablets, the only real downside is that it undergoes the first pass effect. This basically means that 20 to 40% of the drug is lost before it even reaches the bloodstream. Now, tablets are also ineffective if the person themselves are incapable of swallowing them. Some alternatives to instant-release tablets are suspensions, suppositories, and intravenous injections. So first off, suspensions provide a great substitute for swallowing tablets, but they are still limited to the first pass effect. Now, on the other hand, suppositories are more easily absorbed, and they also bypass the first-pass effect, but they have an undesirable administration method. Now, similarly, with IV injections, they also bypass the first-pass effect, and they also have a very quick onset of action of about 2 minutes, but this procedure is very invasive and can cause pain to the patient. Now, to answer which formulation is more effective than the other, for example, if they have acute pain, instant-release tablets are better. If they have chronic pain, controlled-release tablets are better. If they can't swallow any tablets, suspensions or suppositories are better. And if they're in hospital and need quick pain relief, IV is better. In relevancy to clinical practice, oxycodone is an opioid analgesic, and it is mainly used to treat post-surgery acute pain, chronic cancer pain, and chronic non-cancer pain. So, during treatment for acute pain, the dosage of oxycodone, mainly in adults, is conventionally dosed at 5 to 15 milligrams every 4 hours, with the moderate acute pain and older individuals starting at the lower doses of 5, and the more severe acute pain starting at the higher doses of 15. Now, on the other hand, for chronic pain, 2.5 to 5 milligrams is first administered every 4 hours to achieve initial stabilization. This is done to see what dosage a patient needs to have a therapeutic response to the medication. Once this stabilization has been achieved, a control-release tablet can be administered at half the recommended daily dose every 12 hours to the patient. Also, due to oxycodone being prone to tolerance buildup, there is no recorded maximum dosage within adults. Doctors should always prescribe the lowest effective dose to the patient, where as a result of this, the maximum dosage is only limited by the side effects that the patient is experiencing. For renal impairments, patients with a creatinine clearance of 10 to 30 ml per minute should have their dosage adjusted by 75% of the recommended dose, whereas if their creatinine clearance is less than 10 ml per minute, they should have it adjusted by 50% of the recommended dose. Likewise, in patients with moderate hepatic impairment, oxycodone should be reduced to 30 to 50% of the recommended dose, and if they have severe hepatic impairment, oxycodone should be avoided altogether. Now, when first counseling a patient on the use of oxycodone, we first must evaluate that the drug is suitable for the specific patient. This is done by asking open-ended questions such as who is the medication for, what they were using it for, if they have any other medical conditions or allergies, and if they are taking any other over-the-counter or prescription medications. So, when asking about other medical conditions or allergies, we're keeping an eye out for liver or kidney impairments, as we talked about before, oxycodone allergies, as well as low blood pressure and respiratory impairments. This is because oxycodone can also cause hypotension and respiratory depression. Similarly, when we are asking about other medications that the patient is taking, we are looking for medications that cause CNS or respiratory depression. Some examples of these medications are benzodiazepines, barbiturates, and other opioids. Simultaneous use of these medications will significantly increase the risk of drowsiness, nausea, constipation, and respiratory depression. While counseling, we should also acknowledge if the patient is pregnant or breastfeeding. This is because opioids may also cause respiratory depression in the newborn and sedation in breastfed infants. After making sure the oxycodone is safe for the patient to take, another important counseling point is to go over how to take the actual medication. This includes the doctor's prescribed dosing instructions that is printed on the label, as well as explaining how to take the medication. Examples of this are not to break or crush controlled release tablets, taking the tablet with a glass of water, or how to administer the oxycodone if it is a suppository. Along with this, we should also counsel the patient on the side effects that they might experience while on this medication. There are 3 main types of side effects related to oxycodone. The first type is associated with regular use, such as drowsiness, constipation, and nausea. Then there are the ones that are associated with long-term use, such as tolerance, addiction, and depression. And lastly, there are also side effects associated with overdosing, such as respiratory depression, unconsciousness, and induced coma. Additionally, we should also counsel on the importance of monitoring for these side effects, such as telling the patient to monitor their blood pressure if they have hypertension, as well as how to monitor for signs of an overdose, such as difficulty in breathing and inability to stay awake. Also, chronic patients should be advised to schedule regular visits with their GP to monitor for signs of addiction, tolerance, and dependence. Now lastly, another counseling point of oxycodone is to address certain lifestyle changes that the patient should adapt. These lifestyle changes are to avoid alcohol, as it is a CNS depressant and can cause additive side effects, as well as not to drive or operate machinery due to the drowsiness nature of the medication.
Have we ever thought about having a new type of non-addictive opioid painkillers in the market to accelerate our recovery time from pain without increasing the risk of developing chronic pain? Researchers recently tested a novel opioid, an endomorphin, named ZH853, by using rat models of inflammatory pain, morphine, or a placebo. The results showed that rats treated with morphine for a few days recovered more slowly than those given a placebo. This was true whether the morphine was given before or after the injury. The disadvantage is that chronic pain can ultimately worsen due to aggravation of the immune system. However, ZH853 quiets the pain symptoms as morphine and other opioid drugs, but it also diminishes inflammation, reducing recovery time and preventing relapse of pain later. With a drug that prevents the transition from acute to chronic relapsing pain, this would represent a true breakthrough in drug development for pain management in future direction. Researchers hope to begin human clinical trials of the new opioid drug within the next 2 years.
After some initial disorganisation within the group due to a lack of communication, We were able to overcome this by discussing past issues and electing a group leader to oversee the assignment. From this point, everything went very smoothly, with even delegation of roles and deadlines being set along the way to ensure no aspect of the research was overlooked. Following the research phase, we were able to efficiently collaborate to construct a report and final presentation that allowed us to both showcase our knowledge gained in concepts of pharmaceutical sciences and use this knowledge effectively to build our therapeutic and clinical foundation for Clinical Practice 1, which gave us the ability to educate patients on their medications and counsel them appropriately.